I think someone else asked us. Any other questions?
How many hours does it take to complete a kidney biopsy for a nephrotic patient?
How many?
How many hours does it take to complete a kidney biopsy for a nephrotic patient?
So basically, you're talking of kidney biopsy.
Yes.
So basically, one thing I'll just tell you. I can't tell you for sure how many hours. Again, it depends on the surgeon. But those are major surgeries, right? So usually, when you're doing a kidney transplant, I'm assuming it's a kidney transplant or kidney biopsy.
Kidney biopsy. Yeah, I
think.
think.
Kidney biopsy is a very, very straightforward procedure where you take a sample. It's a very straightforward procedure. Nothing. You don't need a lot of surgeons, and it's a very short procedure. Because I don't even think that you need to open up and do it. You can do it ultrasound guided or CECT guided, using those kind of things. So it's a very non-invasive sort of procedure, taking a biopsy. But if you're doing a kidney transplant, that's a different story. It takes a lot of time. You need to have a donor. That will take time, and then you need to make sure that the vessels are properly, identified and separated, so that the new kidney that comes in, that can actually, you can attach. So those kind of things are there, right? So that biopsy is a very simple procedure.
Yeah. The last question: during a major surgery, how long would it take for the patient to become unconscious after the anesthetic procedure?
Very fast. It's very fast. Major surgery, we get all the consent. We put the drugs, right? We inject the drugs, right? The ketamine, different propofol. There are a lot of different agents. You get it within 5 minutes. As long as the anesthetic is happy by performing, give it quickly, intubate, right? After giving the IV drug, intubate, and then connect to isoflurane, which is actually one of the gaseous agents, which I will explain later. That's it?
Yes.
Okay, let's go into this other part which I want to explain. Can someone tell me what this is? It's a very old one, right? There is a pad. So this goes all the way next to us. So we can press this. What do you think this is? With this machine. And there are these areas where you actually, these are gel pads that you apply on the patient. And there is a connecting thing. What do you think this is? Anyway, this is not important, I don't think. We put this underneath, right? So that's one electrode. What do you think this is? Obviously. It's called a.
We do have a answer for that. We don't.
So it's called a diatomy, right? Diatomy, or it's also called electrocauterization, right? So sometimes, for example, when you're doing a major surgery like a thyroidectomy, we can use this particular energy. It's basically a diatom, right? So it uses heat to cut down stuff. You can use heat to, if there is a small bleeder, you can actually, make sure to carry out hemostasis, right? Actually, just using a diatom. So there are different principles. There's a bipolar, there's a unipolar, right? So monopolar. So based on that, you can actually, do different sort of things with regard to this machine. It's good as compared to using a simple scalpel because it will minimize bleeding. It will, it gives you a better access, and because when you are bleeding, you can't see, right? So then that will actually disrupt the surgeon's view. So because of that, it is actually very easy when you're using a diatom. But some people don't like. Some surgeons don't like it, right? Because they say that it destroys the adjacent nerves. But again, it depends from one surgeon to another, right? So some surgeons don't like it a lot of times, but they sometimes use it only when it is absolutely necessary. Right. I think that's one part. I think shall we pause? Right. I mean, you can also finish this area also. Right. So this is an area where we have actually kept all the other stuff. Extra stuff that is required. Gauze towels, bandages. I think there are kits. Different instruments that are required. They have the surgical caps. Right. So and this is basically an area where they have the rescue. So this is the most important thing. Right? This is the most important thing for the anesthetic. This is where the whole process of anesthesia comes into play. Where you give the oxygen, right? I told you the oxygen can be given from here. This only connects into the ET tube, and then based on that, they can mix it with anesthetizing drugs. This is actually seroflurane, this is isoflurane, and there are different there's seroflo. Anyway, there are different things that gaseous anesthetic agents that can be with the mixture of oxygen during the procedure. The nitric oxide also out here. Nitric oxide is also known as laughing gas, right? That can be given, right? And they have their particular equipment, which is pretty much the same thing. right? So that's pretty much overall viewpoint. They have a phone, for example, if there is an emergency, for example, if we need blood transfusions to be done, right? We can call the transfusion team in the blood bank and tell that we need no negative blood or what type of blood. So all of those things also can be conveyed via the telephone. We have the area where we can actually put up clinical waste, whatever things that actually come in, they have the clinical waste that can go in. And then, for example, sharp things can be put into a needle box, that box that are there, right? So that is just the overall viewpoint of what actually happens in the OR. So today's plan is to actually show you the ways that we scrub. I'll show you a hand washing technique, which is a very common technique. I'm sure you all know, and how it is done. How do you clean? I will do that. And then how do you actually, get ready for a surgery? And then I will show you a few things with regard to, we have our normal process where I can show you a few suturing things and all. That's it. So is there any questions? Feel free to ask. So we'll pause for a bit for like 5 minutes and we will continue.
We will join you shortly. Please stay online. And for those who could not get entrance to the Zoom session, we are currently going live on YouTube. And please join through YouTube as well. So just give us 5 minutes, stay online, and we will join soon. I think we exceeded a lot of patients, a lot of participants for the event, and so if there's anybody who couldn't actually join in, please do let your friends know that they can join live through YouTube. I have shared the link to every student, so please ensure that you share it around your friends as well. Dr. Burhan is getting ready for the second procedure. me? If you do hear us, please let us know. If somebody can at least tell me yes, then we can successfully start off.
Yes.
All right, thank you. Also, please let your friends know if at all they were unable to join for the session because of the high number of participants. They can now see us through YouTube. This is going live. All right. Okay.
Okay, guys. Okay, right. So now what I'm going to do is I'm just going to show you how we do a scrub, right? So most important thing, if you got any rings, watches need to be removed, right? Before going to the, now for example, there's a patient. Now I am already like this. I will now scrub. How do I do this? So I will leave this, leave somewhere, right? And now let's go to the place where you know, right? So this is the area where we are scrub. Right, so it's just one basin. Usually, we sometimes have around 2 or 3 in hospital, but this hospital is one. Right. The most important thing is that you need to make sure that your hands are properly washed, and that's the whole process of doing a proper scrub, so that you do not have any microorganisms that are there in your hand that you can actually give you the patient. Obviously, there's going to be we are going to wear gloves and all of that, but we need to make sure that we have that responsibility in washing our hands well. So there are different ways of doing it. But the most important thing at the end of the day, you need to make sure that your hands are properly sterile. Right? So they usually say you need to have washed your hands at least around 5 to 7 minutes. So I will show you how it's done. Right? Now, very important thing, as soon as we come here, my hands should not go down because these are the most sterile areas. This also is sterile as compared to this thing. So they are always got to be in this position because the water, after washing, the water has to drip down like this. Now, for example, imagine I put it like this, the water here or contaminated stuff here will start dripping out here. So that this area gets contaminated. So the way you keep your hands is always in this sort of angle so that it drops down like this rather than dropping down the way down. Okay. So now there are different stuff. You can use only ID, right? So start come from here. Right? So now focus on hand. Right? So let me say that I have the box, objective, rather than in your life. So very important thing, you have to use this, use the elbow without using your hand. Right? You always use the elbow. Unwanted sound. Now you can see this is bad. Now this is basically whatever I'm touching here, whatever contamination is coming down here, right? So same way when you're using the vector stuff, you can always get it from here, right? So now the principle is that you start washing in this way.
Right? So student is asking what exactly you are using to scrub the hands.
So out here they have something called vector scrub, which is having chlorhexidine. So there are different reagents that are there. You can use codeine, iodine. There are different. So chlorhexidine is also one of the scrubs that can be used before the surgery, right? So now the first scrub, right? So there are 2 scrubs that we do. Now you can see the first scrub involves all the way until the elbow, right? So I will actually first nicely do a general scrub of the area, right? And then after I have done all the way at the elbow where I have gone in a circular motion, then I will start my general scrub of the hand, which is the most important thing. So you will notice that my hands are always going to be in this sort of stance. Right? So first I will do a general scrub, and then I will go interlocking these 2 areas. Very important because these areas should not be missed. So I will be doing this interlocking mechanism between the palm, the palm area, right? Then I will do the interlocking from the other side. So you do it on one side, and then you do it on the other side. Right? After that is done, you will do these areas. So you have this sort of thing, and then you do it on here, right? This and this. Right? Then you do it for the nails. I mean, usually there are these nail things. I mean, it's not here, you have a separate thing where you can wash your nails. You can do it before. For example, if you're having a lot of surgeries for a day, you can do that in the first one, and then you don't have to do it. But we normally do it this way so that we actually focus on our nails, right? So it's very preferable that you do not have nails. But unfortunately today I have. So anyway, it's okay, right? So after you do that, then you go for your thumbs. You go for your thumbs, and the final part, a lot of people forget, you need to wash the distal creases. You wash the distal creases. And then after that is done, right? After, this basically takes around 2 minutes. So I'll start, anyway, I'll be doing it again, right? So then afterwards, let's just wash. So now when I'm washing, you will notice, right? I will be doing it out here. You need to make sure that's the first scrub, right? So now we're going to go to the second scrub. The second scrub, right, will not involve, the second scrub will not involve this portion. It will only involve the hand, right? So again, I will take the recto scrub or the chlorhexidine, right? And then I start my normal scrub. So I'm going to do it very slowly this time. So it's palm to palm initially, wash it nicely, right? Palm to palm, and then you go on the other area, right? Again on the other area, then you interlock from one side and making sure that this is nominal, properly doing it, and then you go on the other side, and then again vice versa, right? And then you switch, and you do this clinching mechanism. You're washing these distal areas, doing the same way on the other side, right? Then you work on your nails. Out here, the nails, same way, you just feeling this, and then your tongue, because you forgot your tongue when you were doing this, your tongue didn't get it. You have to focus on your tongue. Tongue on this area, right? And then the final thing which a lot of people forget is the pharmacopoeia. Very, very common thing, medical students also forget. So after you're done with this, again, is getting more. Now, very important thing. And now you can see everything is actually going down, right? You should make sure that your hands are always going to be like this. The moment I put it down, it's going to, this water, this water, whatever, then it will come down here. It will always fall down. I think I'm done. Right? Then, now I'm ready. So I'm ready that this area of mine is completely, it's completely set. So after I come here, now this area is the area where you have to get prepared for this. Right? You have to get prepared for this. So first what I do is, right, now sometimes you take this towel, imagine this is a sterile towel, right? You take it from one aspect, start from your hands, right? Making sure, because this is a sterile towel, huh? Imagine this is a sterile towel, I don't know if it is sterile. Right? And then after you have gone down here, make sure not to use this particular area. Now I can't take this towel and wash it because you have to start from the physical aspect and then only come down, right? So now imagine this. Now what normally happens is we have another towel, right? But for this purpose, I don't have two towels because obviously we're not doing surgery. So imagine I take another towel, I take it from this hand, it's sterile, and then start again. You're wiping all the areas. Again, the same process when you're wiping, right? Now again, I can't come back. So now this is done, and you just put it. There's an area where you can put it. You can put it down. Don't bring it back here. Put it down, right? Next part is wearing the gown, right? This area of this typical thing which we have in our hospitals also. So you get this particular gown in such a fashion. You hold it from here, right? Now, very important. You hold it from the tips, right? This area is actually completely sterile. You take it. Then the system will come and actually tie it from the right? The system will come and tie it. Is it there? Okay. Yeah, this is now there are a lot of different. Yeah, so it's basically there are different methods. Like I said, there are different methods. Right? I don't know what was the method that was actually being used at that time, but people have developed it. Now, when I was actually studying medicine, we learned that there are different people. I will not say medical school. I will say so, but that is the case, and then you would have a sort of surgical solution, two or three surgical solutions, and then you put your hand, right, and you soak in one hand and then go into the other. Go in another one. So there are different methods, but this is the current WHO guidelines on how you actually wash your hands. There can be a few different things based on specific. So now here in Sri Lanka we have this kind of system that you need one assistant and that assistant will actually do it. But there are ways that the over now I have to take it off. Sometimes in a lot of hospitals where it is available, there are one of the nursing officers will make sure that nursing officer will be responsible in making sure that he or she will actually make it wear the gown. You don't have to do anything, you just put your hands, she does everything in a very sterile way. Right? So that's the difference. If someone can actually tie this from the back, right? So when the person is doing it, that person also should be in a very important way where should not touch the other because this is all sterile, right? Okay, good. So now these gloves. Now I'm supposed to wear the gloves, right? So now these gloves are not the like in the sense that even though this is a sterile glove, but right now I can't touch it because now I'm sterile, but this area is not sterile. So normally they don't leave it like this, right? But what happens is the nursing officer comes in. So the nursing officer will come and actually open this up. Now in this instance we don't have it. So imagine a nursing officer will come, right, and will actually, without touching the compartment, we just drop this down here, right? So it's dropped here, right? Same thing with this. They hold it and you drop it without touching that, because this packet is sterile, whereas this is not sterile, right? Which was actually this is not sterile. So now obviously we are not doing a surgery, so I just did what the nursing officer should have done. But it's okay, right? So now some might ask, why do you need two gloves, right? But right now we live in a world where there are a lot of people who have HIV and all of that, which is why we make sure that all surgeons actually, whenever you're performing a surgery, because if it is cut, if the patient is having HIV or whatever, you can get infected. So because of that, we make sure to that. Right, so I'll just show you how it's done. So normally I wear a 7.5 plus. You face it upside down. Right. So what you need to make sure is this whole area is sterile. This glove part is sterile, but you can touch this area. Right. So now, for example, I take this now without touching the things that are outside. I can touch what is inside. Right, because the outside is what's important. So can you see I'm holding from the inside, not from the outside. And then I just do this. And the other one is a sterile glove. Right? So I can't touch this area, but I can touch this area. Right? Sometimes a lot of people require you to do it, but I just use one hand. Now can you see? Now for this purpose, my hands are sterile. I put my finger in between. Now I'm not touching the inside one, but I'm touching the outside. Take this. Yeah. Right. So now when I put it, I'm make sure that this whole thing goes inside. So there are different mechanisms where you can do this. You can close this, right? Close it. This sounds a little different, but right, so it properly stays. Same thing you can do it with here. You can hold it from here. Right? You know that it is going to be better. This will actually make sure there is no sort of barrier. There is no skin barrier when I perform. All of these are covered. Right? And then I'll show you the second one. Again, very straightforward, nothing fancy. Now you need to understand that both are going to be sterile, so that is why I will use the same principle. Can use this area. I can touch because this is basically sterile, considered sterile because I'm not wearing it on my hand. It's a sterile surgical glove. And then you can pull this away. And same thing with the other side. So I'm ready, right? So that's pretty much it on how you actually go in. Now, before that, you're supposed to have a surgical cap and all of that, right? So you walk in, right? Now imagine, I'm sure most of you all have come to a sort of. Someone can pick this up. Now I can't touch. So these are all. I can't use my listing. I can use my. I mean, you should not, right? So you can put it on the operation. Like it. Great, right? So now imagine now we're going to do a surgery, right? Imagine there is cut or something. So I will just show you. Now, for example, imagine this area is an area where we are going to perform a surgery, right? So, or for example, if there is a lump here, right? We'll take a completely different area. There is a sort of a lump inside, right? So first thing first, before now, imagine if you're doing a local procedure, right? Not here. So I will take. I mean, we don't have the local anesthetic or anything out there. Did not ask for, right? So I will take the local anesthetic. Mix it the way I want. Now, if I'm going to make an incision here, I will do a blocking. This thing I go in. Now imagine that there is a local anesthetic. I'm just saying that. I mean, we don't have that. It's not there. But I will actually inject. So before I inject, I always withdraw. Why do I withdraw? Because when I am actually injecting, sometimes I might have actually infiltrated the blood vessel. I can't be injecting into a blood vessel. I can only inject into the soft tissue, right? So whenever there is fluid, right? So when I go in, I just check. I just lift it up. So if by any chance it comes up with blood, I need to withdraw a bit or go a little. I mean, withdraw a bit and then only inject. Every time before injection, I have to withdraw to see if I'm getting any blood. If I get any blood, that means I have hit the vein or I have hit a vessel. So if I inject this lignocaine agent, will go directly into the blood circulation. That is very harmful, right? So that is why it's very important that this principle is known. So now I give the local anesthesia out here, then I come here, do the same procedure, give it here, right? And I've given the local anesthetic. So this area will become numb, right? So this area is numb. Again, you can't close these things. I'm just doing it because I don't know. This is required. Right. Great. Right. So now imagine that we've actually got this area that was there, and then we make an incision. Find the lump, take the lump out, and now we come to this area where we have made an incision, we have found the lump. Now we need to suture, right? So that's what we are going to do. So I'm going to be teaching you all about the suturing things that are there, right? So we have a few things that are commonly used. This is called the needle holder, right? This is the surgical forceps. The reason they're called surgical forceps because they have tooths. You can see there's a tooth. There is something called an anatomical forceps. It doesn't have this tooth. So the tooth is there because it helps to grasp. If there was no tooth, it will just slip off. That is why these are called surgical forceps. And then we have clamps, right? There are different clamps. If you want to clamp this area for an artery, if you want to clamp, you can actually do that. Are there any questions? No.
We don't have any questions. If you have any questions, please do drop in the chat
So
box.
this is a separate curved surgical clamp, also called a mosquito, right? And this is another clamp that is a straight clamp. Can you see this is curved, right? I don't know if you can appreciate it. It's a curved mosquito. It's not straight. Yeah. Well, now if like the way just now Mandy did, it's absolutely wrong. right? Someone you can't contaminate this operation field, right? So you can see it's curved. It's not straight as compared to this. This is straight, right? So anyway, these are actually good for for hemostatic clamps, where you clamp an artery or a vessel if it's bleeding. For example, if it's bleeding, I will clamp it and then I will tie it. Things like that. Imagine there is a blood vessel. I clamp it like this, and then I will put a tie to make sure that I put a ligature, and it's great, right? So that's that. And then we have a normal scissor, a surgical scissor, when we want to cut, right? So these are the equipment that are there. So we are going to be suturing, right? We're going to be suturing. So there are two different kinds of sutures that are usually there. I mean, there are a lot of different kinds, right? So we have something called a vicryl. There's a way that you actually do. There's a 2-knot vicryl, 3-knot, 4-knot, 5-knot. Same way you have. This is proline, right? So 2-knot proline, but they come into two different categories. This is considered an absorbable suture, right? This is considered a non-absorbable suture. Okay, what is the difference between an absorbable suture and non-absorbable suture? I think you all know. If someone wants to answer, you all can actually answer. What is the difference between a non-absorbable suture versus a non-absorbable suture?
The absorbable sutures, they dissolve in your body, and then
Exactly.
you don't
Now,
have
for
to
example, when you're doing
move it after
for
the mask.
example, very good. Right. So now, for example, imagine that I want to actually put a suture here. Right? Can I put proline? It is a non-absorbable suture? No, because that is going to become a problem. It doesn't dissolve, and it can cause a lot of problems. There can be foreign body granulomas, all of those things. To avoid all of that, we put absorbable sutures within inside. Right, inside when we are actually closing the peritoneal cavity, or if you're putting any ligature, we always use vicryl, right, which is an absorbable. Proline is used when it comes to when it basically comes into suturing the outside, right? And sometimes, for example, when you want to put a mesh for a hernia repair, when you want to put a mesh, sometimes just because we want that mesh to stay there, it's like a mesh to strengthen that area so that the hernia doesn't come in. We can use proline or non-absorbable suture. Otherwise, generally, absorbable sutures go inside, non-absorbable sutures here, right? So we'll break one, Mr. Amil. We don't need this one. So I'll just take one out. Yeah, so there is a very good question from Mr. Amila. Sometimes if the incision is very small, right? If it doesn't gape, what do you mean by gaping? Sometimes when you make a cut, it gapes like this. So by pasting it, now Mr. Amila said, is there anything that you can actually paste? There is a thing called steri-strips. It's called steri-strips, where you can actually paste it. It sticks on this end and this end, and it helps to close. Because the most important thing with skin is that if you can just make sure that there is no gaps and you have made this thing, the fibrosis will take place and properly heal, and that's how you can form scars. Right? You'll either it can heal very well, or sometimes you can develop a hypertrophic scar or a keloid. Right? So there are principles, and in Western countries, sometimes the incision small, there are glues. Right? You can put a glue and you can stick. But in Sri Lanka, generally, and then there are other things. Without putting sutures, you can put staplers. We have staplers that you can actually use. But for today, we are going to be using a straightforward suture, right? Which is proline. So again, this is a non-absorbable suture, right? I'll use the needle holder, right? Let us take it, right? Yes. So very important, the way that you hold the thing, how you connect, right? So you will learn when you study surgical principles, right? You don't put the suture, you don't put it out here, right? You don't put it in the middle, but you keep it 1/3 from the area where the suture material starts. So the needle has to be clamped 1/3, and it has to be at the tip, right? Now these can you see, this is actually not good. This is not a very good needle holder. Can you see that it has not properly held? There is a gap. Usually there should not be a gap, right? Because otherwise it will just fall off, right? So that is why, I mean, anyway, I'm not going to stop complaining about these equipment. These are all equipment that we got for a long time, right? So, it has to stand. So you see it's at the tip, and it is covering 1/3 from the tip of the needle. I mean, from the non-blunt end of the needle, right? And then we take our surgical forceps, right? I grasp one area. Now, for example, if I'm putting a suture here, so very important, you just don't just put, you go 90 degrees, right? And always you never put sutures in this direction. Your sutures start from the opposite end. Now, for example, if I'm working from this end, right? Usually the surgeon actually prefers to stay on the left hand side, but I mean, on right hand side. But usually I just start on the left hand side of the patient, right? So it depends, and then you go down. I'm just going to show you a simple suture that you go down. Usually, I don't prefer touching the needle because a lot of people sometimes you have to because now this is now when you now if I have it like for example this is around a long way, it's around 1 centimeter approximately. So you make sure that it comes there, but you should not. This is too much. You can go again up to around 1 centimeter, but you make sure it comes from the same area. Then you use it, right? Now you will use the mosquito just to show you how you put the suture. Now you come all the way at the blanket. You roll it twice. Right, you can roll it twice. Get this area. Then so you don't pull too much because if you pull too much, it's going to become too tight, right? So you keep it as long as it has come properly closed in that area. That is enough for you, right? You put another tie. Then you put another tie. When you're happy, you can. Now, usually an assistant is usually there, right? I will normally have an assistant. And now here I will only be doing it, and I'll get the assistant to cut. Usually you keep a little space because these are non-absorbable sutures. Don't cut too much because someone has to remove it at the end of the day after around 7 to 10 days, depending on where the injury is. Right? And then you cut it somewhere so that they can hold, and then that is done. One suture is done. So different sutures. Right? This is just a very simple suture. Then you have other sutures where you can actually make.
Doctor, there is a question
Yeah.
from the student.
Yeah.
Are butterfly stitches the steri-strips used during a surgery?
No. Usually when you're performing big surgery, you can't because there's a lot of gaping. Gaping when it's like this, you understand? I don't know. Gaping is it's an English word. It's gaped, right? So when there's a lot of gaping, you can't put because you can't bring these two together. You need something very strong, like a stapler or like a suture material to hold them together. So it's very, very rarely done, right? But yes, staplers are used, right? So staplers danakota, you bring this here, and there's a sort of staple. You know how the staplers are, but they are hand here. You can hold from hand. That's how it works. Okay. So that's pretty much it. I mean, there are other sutures also. This is a simple suture. There is something called a continuous suture. So what do you mean by continuous suture? I'll just show you quickly. Right? You put the first tie, right? You get this, right? You put the first tie, and then you continue go on. Right? So you can do that. For example, if you're stitching the fascia or something, you can go on. Like you put this, right? One of that. I can either cut this or I can't. I can either cut it. Just cut. Now there I cut both. No? So here I'll just cut this portion. Right. So I'll just cut without cutting this. I'll just cut. Now here we cut both. I'll only be cutting the short end. Right. I cut the short end, and now I will continue. We call it continue. Need to make sure that when you're dealing with this, you'll understand there are a lot of issues with you can see now this is one. It sometimes can overlap, right? So then you have knots and all of that. So it can be experience. Right? I don't like to touch with my hand. That's what my consultant who taught me always told me, don't touch with your hand. So now this is getting the weight. So sometimes what I can do, use my other hand. Yeah, got a knot. Now this knot has come in. Very, very complicated, but it's a continuous. Go on. We can go on another few more rounds. We can stop. We can stop at the end. When we stop. Any questions? Are there any questions? So when we stop, what we can do, there are different ways of doing it, right? So some people will put like this and take from here and do it. There's another way where, you know, my consultant taught me, where you can actually, I can't show you both ways because you put this inside, right? Right, you take it 3 times and you pull. Very easy way, but sometimes what happens is if the suture is not very strong, it can tear, right? But it's a very, it looks nice at the end because it's not very complicated. Right, so you put this in the second round. I hope you understand. I'm putting this underneath this. So you can see that I have thrown 3 times, and now I just pull it. Right? Just pull it, and I will persist it.
Another question.
Yeah, no, you can ask.
How do you decide which technique to use the patient? What happens if the patient wakes up during a surgery?
So usually simple suture is what is advised. This was a simple suture. I'll show you. There's another suture when there's a lot of gaping. You can actually put the different type of suture, which actually helps to reduce the gaping. So it again depends on not in the type of the wound. It depends on, you know, if the patient, for example, thyroidectomy, we don't put these kind of sutures because there is a lot of scarring, right? There's a lot of scar formation that can happen with non-absorbable suture. But for example, you need to make sure that if when you're putting an absorbable suture, you need to make sure that the surgery is a clean surgery. There's no chance that it can get infected because absorbable sutures have a higher predisposition of getting infected as compared to an unabsorbable. So it again depends on a lot of things. I can't just generally say wound for this we put this. It's very difficult. It again changes from person to person. It changes from procedure to procedure. It changes from the patient's requirement as well, right? So that's that. I want to show you one more suture. I think that will be the last part. If there are any questions, please ask. And I'm just going to.
If patient,
Okay, so that if it happens, the anesthetic will actually try to, you know, put the patient back. Okay, so this is the other suture that I am going to show you. So then that, no, so then again you need to secondary suture. If it opens up, right? So then you need to actually, you know, go back again and suture. Right? So if it opens up, it is this thing. So you take a deep, you know, you go deep. So that means you've gone into deep. This is for gaping sort of sutures. Yes. Right? Then now here a simple suture would have ended where I would have put a knot. But here I don't end here. I'll go again superficially from this end. will come out again superficially, very superficial. Understand? This will ensure that if there is a gaping, if it's like properly gaped, I can actually close it. Right? So
There is also another question. How to prevent appearing a scar after surgery? And does absorbable surgeries give less marks after surgery?
true, absorbable sutures have less scar marks. Right? The way you can avoid it is there are a lot of things. You make sure that you can remove the sutures on the right time. Right? Sometimes when you actually keep sutures for a long time, you will actually develop more scars. So this is anyway, forget about this. So your question was with regard to the type of sutures. So absorbable sutures will cause less scarring. That is one. Other thing is absorbable sutures. Actually, there are a lot of indications as to when we do it. For example, for cosmetic purposes, it's really good. Imagine you put an unabsorbable suture, you can reduce the chance of scars by removing it at the right time. That's one. If the scar formation is there, you can actually, there are a lot of preparations that are there you can apply onto the scar tissue that will reduce the chance of scar formation. Any more questions? I think that's pretty much it. That sums up what we were planning to do today. I hope you guys enjoyed. I hope it was, the whole point is when this whole COVID pandemic actually gets better, our plan, IMC's plan is to actually, get the students. We've had a session like that with a few more doctors where we had CPR, all of that. Hopefully when all of this gets a little settled, we can actually, do all of those things for the student. Also, if y'all are interested, y'all can always join the free medical anatomy classes, not anatomy classes, but the free medical classes that are there. You can always feel free to contact your counselor and then he or she will actually.
There's a question.
Yes, go.
What happened when sutures kept for a long time?
So what happens is sometimes they can go deep inside. It becomes very difficult to remove the suture, right? I can show you. I mean, right? The reason I told you to keep a bit is because when you're removing it, the person will remove it, pull this. Make a chutta, look at it, right? And then from the side, they will just cut it. So it will make sure you cut it properly came. See, the whole suture is inside, right? If it's kept for too long, it will cause too much of scar formation. Second thing is it will actually be difficult because the suture also has got involved in the scar. So it's pulling. So sometimes it's very difficult to take the suture. Any more questions? I think we have come at the quota of our time also because Park hospitals will need to use the operation theatre for the purposes. If there are any more questions, just let me know and I will answer.
I think we're done with it.
Yeah. So again, after you're done with the surgery, take it off, take it off. You will get more. And then you can go wherever there's an area, I don't know, there's no area. So intervention and normal leg does not have any starting bladder in it, otherwise you have to put in the liquid. Right. I think that's pretty much it. Thank you very much. Best of luck with your medical career for the ones who have actually joined us from Belarus, who already started medicine. Wherever that you all have gone. If you all are from my alma mater, that is Vitebsk State Medical University, which is in Belarus, best of luck for your future. If you're from Grodno, whichever university, best of luck. If you're starting up, for the ones who are interested in doing this, Malaysia, wherever that you all have actually planning to go, make sure that you do it very well. Learn because it's going to be the most important times of your time in your medical career. The medical school time is the most important because you will learn that foundation, and that will one day you will be able to, after doing all of that, you will be able to come to a place where I am right. So it is not impossible, but it involves a lot of hard work. I guess that's it. Thank you very much. There are no questions. Okay. So thank you for being back.
Yes, thank you to everybody. Please do speak to your counselors and get your consultations done right. Do speak to them and get your consultations booked. You can drop a text to them or you can the education. All right. And also, please know that Dr. Burhanuddin Hamza conducts free medical preparation classes, and every one of you can come and join it. So this is a huge welcome to everyone. Please do reach you how you need to join the classes. Like I told you again, if you are planning to enter to a medical university, you can get the consultations done by IMC Education, as we are the official agent in Sri Lanka, which is why we actually arrange such events in this school. So we are hoping to see everybody at IMC for your consultations. Counselors and get your appointments booked for a free consultation session regarding your medical university. Point number 2, do speak to your Dr. Burhan, do conduct medical preparation classes that are fully free of charge. And if you want to join his classes, do call us immediately and your appointments with the assistant, Dr. Ms. Ashwita, Ms. Sumaya, Mr. Amila, and Mr. Intikab for more information. Thank you very much for being a wonderful audience and hoping to see you again for the next event. Thank you so much.